Welcome to our video on SIADH and diabetes insipidus. Let's get started. Here's our overview slide. Let's begin first with syndrome of inappropriate secretion of ADH, or SIADH. With respect to SIADH, we'll discuss the definition, etiology, pathophys, clinical features, diagnosis, and management. Let's begin by reviewing the definition. Hopefully from its name, you can deduce that SIADH is caused by excessive ADH production. ADH production is independent of serum osmolality. There are many causes of SIADH. It can be drug-induced, for example, selective serotonin reuptake inhibitors, NSAIDs, and carbamazepine can cause it. It can also be due to disorders of the central nervous system, such as stroke or trauma. Pulmonary disorders can be responsible as well, such as pneumonia and COPD. Finally, ectopic secretion of ADH from neoplasms, particularly small cell lung carcinoma, is an important cause that you should be aware of. Before we dive further, let's review some pathophysiology. We know that ADH works on renal collecting ducts, leading to water resorption and concentration of the urine. So increased ADH production causes increased water resorption. This leads to two major abnormalities. First is water retention and increased total body water. Second is inappropriately concentrated urine, and thus decreased urine volume. Water retention, in turn, leads to other abnormalities, including hyponatremia with low serum osmolality, as well as extracellular volume expansion. ECV expansion stimulates and increases the release of atrial natriuretic peptide. It also inhibits the renin-angiotensin-aldosterone system and increases the glomerular filtration rate. These mechanisms lead to natriuresis. It's highly important to know that natriuresis is responsible for euvolemia. So, despite water retention, the patient does not present with peripheral edema or jugular venous distension. However, natriuresis also leads to worsening hyponatremia. All right, let's solidify some concepts with a review question. A 25-year-old male is brought into the emergency department by EMS in a comatose state. According to his significant other who accompanies him, the patient has a long-standing history of trigeminal neuralgia. Laboratory workup is notable for a serum sodium level of 115 milliequivalents per liter. What is the likely etiology of this patient's hyponatremia? All right, this patient presented in a comatose state, most likely secondary to his severe hyponatremia. It's important to narrow down the etiology of hyponatremia. Given the history of trigeminal neuralgia, it's likely that this patient takes carbamazepine. Recall that carbamazepine is typically the first-line treatment for trigeminal neuralgia, and also that it has many testable side effects, one of which is drug-induced SIADH. So in answer to the question, the etiology of this patient's hyponatremia is most likely due to a side effect profile of carbamazepine. All right, let's move on to the clinical features. This largely depends on the severity of hyponatremia. In mild hyponatremia, patients can be asymptomatic. However, nausea, forgetfulness, and lethargy can be found. On the other hand, severe hyponatremia can result in profound confusion, seizures, or coma. Patients are euvolemic, as we discussed earlier, so there will be no edema or jugular venous distension found on physical exam. And the mucous membranes should be moist. Before we move on to the diagnostic findings in SIADH, let's take a look at the algorithm of hyponatremia from our lecture on sodium disturbances. When a patient presents with symptoms or signs of hyponatremia and a low serum sodium is confirmed, meaning that the serum sodium is less than 135 milliequivalents per liter, one approach is to measure the serum osmolality. If the serum osmolality is low, we move on to measuring the urine osmolality. If the urine osmolality is not lower than 100 milliosmoles per kilogram, and the patient has no signs of hypervolemia or hypovolemia, then the causes that should be considered are SIADH, which is the most common, as well as glucocorticoid deficiency and hypothyroidism. So here are the laboratory findings that are typically seen in SIADH. As we mentioned earlier, increased water reabsorption from collecting ducts leads to inappropriately concentrated urine, as well as water retention that results in hyponatremia and hypoosmolality. So the serum sodium is low, below 135 milliequivalents per liter. Serum osmolality is low, below 275 milliosmoles per kilogram. Urine osmolality is high, typically over 300 milliosmoles per kilogram. And the urine sodium concentration is elevated, typically above 40 milliequivalents per liter. Also, the serum potassium and bicarbonate remain normal despite dilution. Potassium is released from cells to reduce cellular swelling and hypoosmolality, which keeps the serum potassium within a normal range. Movement of hydrogen ions into cells, as well as increased hydrogen ion excretion by renal tubules, keeps the serum bicarbonate within a normal range. Finally, the serum uric acid is often low. This is due to increased urinary uric acid clearance, likely as a result of water retention in SIADH. To discuss management of hyponatremia in SIADH, we'll also use our algorithm from our lecture on sodium disturbances. The initial management depends on whether the hyponatremia is acute or chronic. If it's acute, meaning that the symptoms developed in the last 48 hours, hypertonic saline should be administered. If the hyponatremia is chronic, meaning that the symptoms have been present for more than 48 hours, we assess the severity of symptoms as well as the serum sodium level. For severe symptoms, such as seizures, or if the serum sodium is lower than 120, then hypertonic saline should be administered. However, if the serum sodium is between 120 and 134, identifying the cause and reversing it should be considered, as well as limiting water intake. All right, let's try another question. A 50-year-old man presents to the emergency department with profound confusion. He was diagnosed with SIADH and administered hypertonic saline. 3 days later, he developed dysarthria and quadriparesis. What is the most likely cause of this patient's symptoms? All right, from the question, we can see that we have a patient who is diagnosed with SIADH and given hypertonic saline for correction of hyponatremia. But later, he developed dysarthria and quadriparesis. These neurological findings should make us think of osmotic demyelination syndrome. Recall that osmotic demyelination syndrome is destruction of the myelin sheath of axons, most commonly in the pontine white matter, secondary to rapid osmotic changes. So it's most commonly caused by overly rapid correction of serum sodium in hyponatremia settings. The presentation is typically delayed 2 to 6 days after rapid correction of sodium. This includes dysarthria, dysphagia, altered mental status, quadriparesis, and coma. It can also result in locked-in syndrome. Here is an MRI image of a patient with osmotic demyelination syndrome. Note the hyperintense area in the pons. There is also a classic trident-shaped appearance, which is caused by involvement of the transverse pontine fibers and sparing of the corticospinal tracts. Now let's move on to our second condition here, diabetes insipidus. Again, with regards to diabetes insipidus, we'll discuss the definition, etiology, pathophysiology, clinical features, diagnosis, and management. Here is our algorithm for diabetes insipidus. We'll use this when discussing the diagnosis and management of diabetes insipidus. For now, let's begin with the basics. Diabetes insipidus can be defined as passage of large volumes, typically more than 3 liters per 24 hours, of dilute urine that is less than 300 milliosmoles per kilogram. It's classified into central diabetes insipidus and nephrogenic diabetes insipidus. Central DI is characterized by low or absent production of ADH, while nephrogenic DI is characterized by resistance to ADH in the kidneys. Central DI can be due to many causes. However, idiopathic central DI is the most common. Other causes include head trauma, previous neurosurgery, hypoxic encephalopathy, and infiltrative disorders such as sarcoidosis and Langerhans cell histiocytosis. Nephrogenic DI can also be due to different causes. Lithium toxicity is the most common. Lithium can accumulate in the principal cells of the collecting ducts and interfere with the effects of ADH. Other causes include hypercalcemia and hypokalemia. These electrolyte disturbances can impair the urinary concentrating ability, likely due to interfering with the action of ADH on collecting tubules, as well as decreasing sodium chloride reabsorption in the thick ascending limb of Henle. Finally, nephrogenic DI can also be congenital. Let's review some physiology of antidiuretic hormone from step 1. Antidiuretic hormone, or ADH, which is also known as vasopressin, works on both the vascular smooth muscle cells and the renal collecting ducts. First, It can regulate blood pressure and cause vasoconstriction through activation of the inositol triphosphate signaling pathway. This is achieved by binding to the V1 receptor on vascular smooth muscle cells and activating the GQ protein, which eventually increases intracellular calcium and it leads to vasoconstriction. The second and most important function of ADH is regulating the serum osmolality by increasing water permeability in the renal collecting ducts. This is achieved by binding to the V2 receptor and activating the CAMP signaling pathway, which increases cyclic AMP in the cytosol. This eventually leads to translocation of aquaporin channels, which move to the apical membrane of the principal cells, resulting in increased water reabsorption in the renal collecting ducts. Now let's also briefly review the pathophysiology of diabetes insipidus. We know that ADH works on the renal collecting ducts, leading to water resorption and thus urine concentration. So, a deficiency of ADH or a resistance to ADH in the kidneys leads to loss of fluids and high serum osmolality, as well as impaired urine concentration, which results in polyuria and dilute urine. A patient with diabetes insipidus can present with polyuria, polydipsia, and nocturia, which is frequently waking up at night to urinate. So here's our algorithm again. Now let's discuss diagnosis. When a non-hospitalized patient presents with polyuria and polydipsia, the three most common causes to consider are diabetes mellitus, primary polydipsia, and diabetes insipidus. The most important laboratory results to look at are serum glucose, serum osmolality, urine osmolality, and serum sodium. If the serum glucose is elevated, diabetes mellitus is most likely. If the serum glucose is normal, this excludes diabetes mellitus as the cause of symptoms. We then measure the serum osmolality, serum sodium, and urine osmolality. The urine osmolality is low in both primary polydipsia and diabetes insipidus. However, high serum osmolality with mild hypernatremia further suggests diabetes insipidus, and low to normal serum osmolality with mild hyponatremia further suggests primary polydipsia. This is due to increased water intake in primary polydipsia. The next step is performing a water deprivation test, in which water intake is restricted for 2 to 3 hours. Then the plasma and urine osmolality are periodically measured. A measured level of urine osmolality above 700 milliosmoles per kilogram indicates a diagnosis of primary polydipsia. This is because ADH and its ability to concentrate urine are intact in primary polydipsia. However, if urine osmolality is below 700 on periodic measurements, plasma osmolality is above 295, and plasma sodium is above 145, then desmopressin is administered. If the urine osmolality rises by 50 to 100% after desmopressin administration, then the diagnosis is central DI. If the urine osmolality does not change, or if there is only a slight increase, the diagnosis is nephrogenic DI. Moving on to the treatment of diabetes insipidus. For central DI, desmopressin is usually used. This is an ADH analog that has antidiuretic activity, but no vasopressor effect due to the V2 selective action. It can be given intranasally, orally, subcutaneously, or intravenously. For nephrogenic DI, correcting the underlying cause should be considered. A low salt and a low protein diet can be useful in initial therapy as well. Thiazide diuretics should be added to patients with symptomatic polyuria that persists despite dietary changes. These can alleviate water loss in nephrogenic DI by inducing mild hypovolemia, leading to increased sodium and water reabsorption in the proximal convoluted tubules. A 40-year-old woman presents to the office complaining of frequent urination over the last month. There is no urgency or burning with urination, but she states that she has persistent thirst. Her sister was diagnosed with diabetes mellitus type 2 last year, and she is concerned of having the same condition. Her medical history is significant for hypertension, for which she takes lisinopril. Her blood pressure is 130/85 millimeters of mercury, heart rate is 85 beats per minute, and temperature is 37.3 degrees Celsius. Laboratory results show a fasting serum glucose of 95, serum sodium of 148, serum potassium of 4.3, serum creatinine of 1.0, serum osmolality of 310, and urine osmolality of 110. What is the most appropriate next step in the management of this patient? A. Oral glucose tolerance test. B. Fluid restriction. C. Water deprivation test. Or D. Desmopressin administration. So here we have a woman complaining of frequent urination and persistent thirst. There is no urgency or burning with urination. The most common pathologies to think of are diabetes mellitus, diabetes insipidus, and primary polydipsia. The fasting serum glucose is normal, 95 milligrams per deciliter. The serum sodium is mildly elevated at 148, along with a high serum osmolality of 310 and a low urine osmolality of 110. If we return to the algorithm, we can see that this patient has a normal serum glucose, which makes diabetes mellitus unlikely. However, she has mild hypernatremia with a high serum osmolality, which should make us think more of diabetes insipidus. To confirm, a water deprivation test should be performed. So if we return to the question, we can see that the correct answer is C, a water deprivation test. Choice A, an oral glucose tolerance test, would be performed if diabetes mellitus is likely and a fasting serum glucose is non-diagnostic. However, in our vignette, a normal fasting serum glucose with a high serum osmolality and a low urine osmolality makes diabetes insipidus more likely. Choice B, fluid restriction, can be considered after confirming a diagnosis of primary polydipsia. Choice D, desmopressin administration, is performed to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus. This is usually done after confirming the diagnosis of diabetes insipidus. So again, the correct answer is C, a water deprivation test. And that concludes this section.